Good afternoon, everyone. My name is Dr. Jeff Gelblum, and this is our service dog, Scooter, who is a little idgety right now, so he's going to go jump down. And this afternoon, we're going to talk about Alzheimer's disease. You all know about Alzheimer's disease, of course. Alzheimer's disease is a dementia, a form of dementia, typically affecting older folks. And what happens is it causes memory loss as well as difficulty with attention and focus. The reason why it's important for us to have this discussion today is because for the past several years, we neurologists have had drugs available to us for the management of dementia. The problem with these drugs is they do not alter the course of the disease. They basically improve the symptoms of the disease. So what we've tried to do over the past several years is improve memory, attention, and focus, stabilize the mood. But with that, we're treating the symptoms, but we're not actually getting to the underlying condition. The good news is, in the next few weeks, there may, not definitely, but may be a new product available for the treatment of Alzheimer's disease that could actually deplete or deactivate the protein compounds that are thought to gunk up the brains in Alzheimer's patients. So what I want to do at this point is help you understand what is Alzheimer's disease, what treatments do we presently have available, and what could we be looking at in the very near future, literally within the next month, in terms of trying to help families and loved ones who are suffering from this condition. So let's start with what is Alzheimer's disease. Alzheimer's disease is a form of dementia. When we use the term dementia and we use the term Alzheimer's disease, the two terms are not synonymous. Dementia is the umbrella diagnosis or the umbrella description. Alzheimer's is a form of dementia. What are some other forms of dementia? Well, first of all, what is dementia? What's the difference between dementia and forgetfulness? For example, came home last night, forgot where I put my car keys. Does that mean I'm demented? No. Dementia is a problem of memory, and it's also a problem of functionality. So if I forgot where I put my car keys, that's not necessarily dementia, that's just forgetfulness. However, if I forget where I put my car keys and then I get them and I don't quite know what they're for, if I'm not able to recognize those car keys and I have a short-term memory problem, that is considered to be one of the symptoms of dementia. So the definition of dementia is much different than just the definition of forgetfulness. Dementia is a disease, it's a disorder of brain functioning, and it means that the memory capacity is diminished, typically short-term, and something else, some other functional domain is also diminished. So visuospatial, meaning getting lost when driving home. Difficulty learning new items. So you're reading the paper and you can't quite understand what is being presented in the article. Language problems, word finding difficulty, or matters of comprehension. Behavioral problems, agitation, combativeness. Somebody who was always nice is suddenly belligerent. When you hear about those types of symptoms along with short-term memory loss, then you have to say to yourself, I might be dealing with dementia, either myself or a loved one. And that's the purpose really of today's beginning of the discussion. Let's get a working understanding of what dementia is. Dementia is short-term memory loss plus something else. Could be visuospatial, language, learning new objects, behavior, plus something else that is interfering with your ability to do activities of daily living. So there's a functional decline as well as the memory loss, and that really is the foundation of a dementia diagnosis. So what are the different causes of dementia? Because when you come to me as your neurologist and you bring your loved one in and you say, look, mom's having problems with short-term memory, but she's also getting lost, she's not driving so well, her language isn't so clear, she's having difficulty understanding things, she's watching the TV and not quite understanding what's being said, she goes into the kitchen to make a cheese sandwich and she can't go through those operations. At that point, we're describing a dementia disorder. So what are the different causes of dementia? Well, one of the commonest causes is, of course, Alzheimer's disease. That's why we're having our discussion today. What specifically is an Alzheimer dementia? An Alzheimer dementia is a dementia disorder, but we believe that what happens is there are deposits of various inflammatory proteins on the brain cell. These inflammatory proteins are called amyloid, and it's a gunky process that basically clogs up nerve functioning, brain nerve functioning, and that causes the dementia. The first place that these little amyloid plaques tend to hit is the temporal lobe, right here. And that's the area of the brain that's required for short-term memory. One of the most sensitive indicators of temporal lobe injury can also be loss of smell. Now, I know many of you have been concerned about loss of smell when it relates to an acute COVID attack, but you should also be concerned about loss of smell in an older loved one, neighbor, friend, family member, who is having difficulty smelling things like an orange or peppermint or a flower. If someone has a history of being a good cook, for example, and suddenly their cooking doesn't taste so great, and you say, hey, Mom, you put too much lemon juice in this, or Mom, you put too much peppermint in this, and it's very, very strong, that can be one of the earliest signs of a dementia disorder, and often is a tip-off for an Alzheimer condition. That's why in our office, when we're evaluating someone for a dementia disorder, first thing I check is sense of smell, flower, orange, peppermint. We keep those little oils right in our office so that we can determine if there's any deficit from there. So Alzheimer's is a form of dementia. People who've had a gunshot wound to the head, by definition, have dementia. Poor memory, poor functional capabilities with regard to home, etc. People who've had a stroke can have dementia. People with Parkinson's disease can have a dementia. People who are alcoholics or long-term history of drug abuse can have a dementia. So dementia is multifactorial. There's many causes of dementia. The commonest cause is Alzheimer's disease, and that's a disorder, obviously, that hits folks primarily age 65 and older, but certainly there are younger individuals who have Alzheimer's disease. We've seen them plenty of times in our office. So what happens when a patient comes to me and the family or the patient says, look, I'm having problems with short-term memory, my sense of smell is a little off, and I'm having difficulty driving, a little bit of getting lost coming home, I'm not quite sure about how to park the car anymore. Those are the typical features or the historical symptoms of a dementia. And then it's my job to figure out the type of dementia. So a careful examination is performed in the office, again, testing sense of smell. And then we also do a test called a mini mental status exam, where it looks at various aspects of brain functioning, memory, attention, focus, calculation, writing a sentence, etc. And if those scores, if that evaluation suggests a dementia syndrome, then there's a few additional tests that we neurologists have to perform. Typically, we conduct an MRI, a brain X-ray using magnetic rays. Why is that an important test? That's an important test because typically folks with dementia will have shrinkage of the brain. We call that atrophy. And oftentimes in an Alzheimer's setting, that shrinkage occurs preferentially right here in the temporal lobe. And as you've known, if you've participated in my Facebook Lives before, you know you only listen to a neurology lecture from a bald neurologist, because that way we can point to all the areas of the brain that are affected. So oftentimes your MRI will show a temporal lobe predilection, a temporal lobe focus of atrophy that's out of proportion to other areas of the brain. Even in an older patient, we'll see that temporal lobe wasting. And if we see that, that's a very strong suspicion of an Alzheimer type of dementia, different than a vascular dementia, different than a Parkinson's dementia, clearly different than other forms of dementia. There's another form of dementia called hydrocephalus, water on the brain, you drain the fluid out and the dementia gets better. Again, one of the first reasons why I do an MRI is to rule out something that is easily reversible. And of course, hydrocephalus, fluid on the brain, easily reversible. They put a little shunt in, drain the fluid out, and you're back to running the marathon. So if the MRI is suggestive of dementia, Then the next step that we can even undertake is something called an Aimovid Scan. And what is an Aimovid Scan? An Aimovid Scan is a special nuclear scan. It's a PET scan. The patient is injected with a little bit of tracer, a little bit of radioactive medicine, and they lie in the scanner, and then we can see exactly if there are amyloid plaques on the brain. That type of scan is very specific for amyloid plaques. And as I've discussed with you, the amyloid plaques is the hallmark, is the pathologic hallmark of Alzheimer's disease. So when we have an MRI that shows atrophy, shrinkage of the brain, we have a clinical scenario that shows the beginnings of dementia, and then we have a positive Aimovid scan. At that point, we have very compelling evidence that our patient has an Alzheimer condition. So what do we do with that information? Well, over the past several years, the only thing we could do with that information is various forms of therapy, cognitive therapy, where we send the patient for very good types of stimulation of cognition, current events classes, exercise classes, etc. And then there are two medicines that we have historically used. And those two medicines that we've historically used work upon neurochemicals in the brain to help improve brain functioning. And the first class of chemicals that we've used are drugs that help build up acetylcholine. Acetylcholine is a brain chemical that's required for short-term memory. So giving a drug, you may know the names as Aricept, Razagiline. These drugs have been out for a long time. Not Razagiline, Razidine, I'm sorry. These drugs have been out for a long time, Exelon, for example. And what they do is they help build up brain levels of acetylcholine. That's one pharmacologic strategy. And that's typically the first drug that is introduced to an early Alzheimer patient to help improve cognition, to help improve memory. But the problem with these drugs is they do not actually deactivate the underlying disorder. It's kind of like filling up a leaky gas tank all the time with gasoline, but as long as the tank is still leaking, you're going to have a continuing problem. But we use these drugs nonetheless because the data show that those drugs can help improve some of the memory symptoms of Alzheimer's disease. Some of the behavioral symptoms also, there's data to support that. So the FDA-approved drugs that we now have available, that we've had available, really haven't changed over the past several years. We've had drugs that build up brain levels of acetylcholine, and then we have another pharmacologic strategy, a mix and match strategy, where we simultaneously build up levels of acetylcholine, but at the same time, we block down an inflammatory chemical in the brain called glutamate. And that drug class is called Namenda. So if you have a loved one with Alzheimer's disease, you're probably used to hearing Aricept, which is donepezil, plus Namenda, which is memantine. That's a common combination that is used to provide some functional improvement with regard to the Alzheimer deterioration, which is memory problems, cognitive problems, attention and focus problems, visuospatial, behavioral problems. So historically, for the past decade, this is pretty much all we've had. And we use that still to this very day because it's all we've got. So the purpose of today's discussion is to bring you up to speed with a new product or a new class of products that are under investigation right now. In fact, one may actually be approved on or about June 7 by the FDA. So keep your eyes open, watch your newspaper. Of course, it'll be announced in all the media. There's a new product that is under development, review by the FDA, for actually deactivating or lessening the amount of plaque on the Alzheimer brain, the amount of amyloid plaque. So the reason why I think it's very important for us to get together on today's Facebook Live is so that you understand that Alzheimer's is easy to diagnose, is a common disorder, is a severe cause of disability and impairment in folks over age 65, but can also strike younger years, that we've got drugs that have been and are presently available for the treatment of those symptoms, but have not yet been able to deactivate the underlying attack that is part of the Alzheimer disease. But hopefully, in the next several weeks and in the next few years, because there's other similar drugs coming out that are geared specifically to taking down the plaque burden in the brain, trying to get rid of that plaque, with the hope that as a result, patients will have better cognitive capability, better memory, better attention, and better focus. Now, obviously, these new drugs always come with risks. As an old professor of mine once said, for a medication to have effects, it has to have side effects. So sometimes these new drugs can cause irritation of the brain, irritation of brain blood vessels, irritation of brain neurons. But we believe that that risk may be manageable, and that's why we neurologists get paid, is to make sure that the patient isn't having undue side effects from the new medication profiles. But with that being said, this is a very exciting time, mid-May, right now, 2021, very exciting time because we've really got a good understanding of how to diagnose Alzheimer's disease. We've got diagnostic tests that are useful in addition to a careful and comprehensive neurologic exam, which occurs in my office every day. And as a result of all of that research that's gone on, we now have a new drug, possibly around the corner, not yet FDA approved, with some benefits, but some side effects that are going to be able to be addressed by us clinicians. And that new platform of treatment, this new algorithm, may actually allow us to be more adept at preventing further decline in the Alzheimer's setting. Certainly, this is not a miracle product. These new drugs that are coming out are not panaceas. They come with their own significant effect and side effect profile, but there's significant hope for all of us who have a loved one, a parent, a neighbor, a friend, who we suspect is having Alzheimer's disease. So, for purposes of today's discussion, please be aware that there is hope and help for individuals who have a dementia disorder, that we neurologists are very good at making that diagnosis. This is what we get paid to do, that we have diagnostic testing that we can use in the office and in the X-ray department to further confirm this diagnosis. We have existing medications available to help with the symptoms, and that we may, capital M, may have new medications FDA approved in the next several weeks that would actually help limit the progression and the cognitive impairment of the condition. I invite all of you who are in the Miami area or South Florida, if you have a loved one who you suspect is having a dementia disorder, please make sure they're evaluated by a neurologist. Our office is always open, not always, but Monday through Friday, for the evaluation of dementia disorders. And also we've got our Neuro2Go, Neuro, N-E-U-R-O, 2, go.com, which allows you or anyone to have a face-to-face chat over the telephone or the laptop, whatever device you prefer. Have a face-to-face chat if you have concerns about yourself or a loved one or a neighbor or a family member. They don't have to be present. So if you have a concern that Aunt Esther is having problems with early Alzheimer's, go on Neuro2Go.com, just send a little request, and we can set up a nice neuro chat, telechat to discuss some things to be on the lookout for and to see if Aunt Esther needs neurologic evaluation and management. And that's our Neuro2Go product, Neuro2Go.com, Neuro2Go. So I really appreciate your coming today because this is a very exciting time for medical science. We may be on the precipice of a brand new therapeutic breakthrough that will allow us to not only more aggressively treat the Alzheimer's disease, but may actually improve the outcome of the condition. So on that note, I appreciate your time and attention. If there's any questions or you want to go back or share this video at some future time, it's always on our website, fcneurology.net. This always gets uploaded. And if you have further concerns about yourself, a loved one, a family member, a cousin in Arkansas, feel free to log on, schedule a neuro chat, on Neuro2Go, and we will be happy. Either myself or one of my board-certified colleagues is always happy to meet with you virtually and discuss your concerns. So on that note, I wish you all a great afternoon. Keep your eyes open for hopefully some new news, medical news, neurology news coming through in the next few weeks. And as always, I am available to answer your questions. Shoot me an email, go on our website, schedule a Neuro2Go. We're all here for you. Thank you and have a great afternoon. Bye-bye.